Good afternoon, my dear colleagues. Thank you very much for joining me today. Today, we are going together to study the essentials of respiratory medicine for MRCP. Respiratory medicine is a very special specialty or a very special chapter in medicine because, as we can understand, it has its own mindset or its own mentality. As you remember, as far as you can remember, when we started together studying MRCB, and we started first with the cardiovascular medicine, we agreed both together that each chapter has its own mentality or has its own subset of understanding. You need here in respiratory medicine to acquire a particular amount of information in certain particular aspects. And as can you remember, in cardiology, we were so much interested in some details, like the clinical findings, the clinical setting, the pattern of presentation of different cardiological disorder. And at the same time, there was some pattern in ECG, some pattern in the features of presentation, and so on. Respiratory medicine is no different from the cardiovascular medicine in terms of mentality, because here again, should rely on interpretation of our data. We should rely in the clinical setting or the clinical context by which the disease is presenting itself. But again, there is a special feature here in respiratory medicine, that is the radiological pattern of presentation. So with the respiratory medicine, we will discuss different respiratory conditions or different respiratory disease. Each one of them has its characteristic and peculiar and unique pattern of radiological findings that you can find on chest X-ray. By recognition of this radiological finding, it will be very easy and fine for you to reach for your diagnosis. Again, there is some important information also you should derive from the respiratory function test, because respiratory function test will help you to differentiate between two big subsets of diseases, namely the obstructive lung disease and the restrictive lung disease. Each one of them has its own pattern in the respiratory function test, which is reflected in the differential diagnosis list of different conditions, differential diagnosis list of different conditions in the respiratory medicine. We will start today by studying pneumonia and some of the lung infections. After that, we will proceed to lung cancers. Then in the next lectures, you will see the restrictive lung diseases versus the obstructive lung disease. Let's start first by pneumonia. Pneumonia is a lower respiratory tract infection that is characterized by three important information. The first one, fever. Secondly, chest symptoms and signs. And again, we have abnormal chest X-ray. And as you can see here, abnormal chest X-ray is a very integral part in the definition of pneumonia. Pneumonia means that we have a patient presenting with fever, he has some chest symptoms and signs, and again, he has abnormal chest X-ray. For any patient presenting with chest symptoms and signs to be named as a patient with pneumonia or to be diagnosed as a case of pneumonia, he should have fever and should have abnormal chest X-ray. Pneumonia is classified according to the clinical setting by which it presents in the patient. And classification and knowing or recognition or identification of the cause of pneumonia is very essential, because it will help us and guide us for the choice of the proper antibiotic therapy. First of all, we have community-acquired pneumonia. We call it CAP, and this is caused by Streptococcus pneumoniae. This is the most common organism causing community-acquired pneumonia. And you will find some questions in the question banks that you have asking directly about the streptococcal pneumonia as a cause of community-acquired pneumonia. The second one is hospital-acquired pneumonia. Hospital-acquired pneumonia Hospital-acquired pneumonia, it has its own special setting because it occurs after 48 hours of hospital admission, and it's mostly caused by gram-negative Enterobacteriaceae or Staph aureus. Aspiration pneumonia, it occurs in patients with a stroke, myasthenia gravis, palpebral palsy, reduced consciousness level, even in post-ictal or drunk patients, esophageal diseases as achalasia or flux, and with poor dental hygiene, leading to increased risk of aspiration. Aspiration pneumonia is a very important clinical scenario. You will see a lot of questions in the question bank that you have about aspiration pneumonia and the clinical setting associated with this condition. Immunocompromised patients, they are liable to infection with an organism called Pneumocystis joverachi, which was formerly named as Pneumocystis carinii. And I have to mention to you here that immunocompromised patient or immunosuppression does not necessarily mean this patient have an HIV infection, because there are a lot of conditions that are associated with immunosuppressions. For example, patient with leukemia, patient with lymphoma, patient receiving immunosuppressive therapy, and patient on long-term corticosteroid therapy, even patient with diabetes or complicated diabetes, we can consider them patients with immunosuppression or immunocompromised patient. We will see as we go through this presentation today a very special type of very special form of presentation in patient with immunosuppression. Generally speaking, the clinical features of pneumonia, they have fever, we have fever and cough with tachycardia, tachypnea, hypotension. This is a triology of clinical symptoms and signs that is mostly present in patients with pneumonia. The importance of understanding the concept of clinical setting here is very essential, because as far as you remember, in patients with pulmonary embolism, we have also the patient complaining of tachypnea, tachycardia, and hypotension. But the issue is here that we have patients with fever and cough, So this clinical scenario favors a diagnosis of pneumonia over a diagnosis of pulmonary embolism. But if it was mentioned to you in the exam that the patient has a long-term flight or has a history of DVT or has a history of venous thromboembolism or any coagulopathic disorder, so you might think about pulmonary embolism rather than pneumonia. This is very essential concept here that you have to acquire. The clinical setting itself or the clinical scenario or the clinical context will guide you to the diagnosis. Don't ever try to interpret clinical symptoms and signs in isolation from the history or the clinical setting of the patient. Again, we have confusion of this patient, and confusion is very important criterion or very important feature in patient with pneumonia, as we will see later. Constellation of consolidation, and this term refers to a certain group of clinical signs that if I find it present in one patient, I would conclude this patient that may have a consolidating lung disease. It includes diminished expansion of the chest, dull percussion note of the chest, increased tactile vocal parameters, vocal resonance, and bronchial presence. The presence of this constellation of symptoms of constellation of clinical features, it concludes that this patient has a consolidating lung disease. So let's move now to the investigation for pneumonia. Our basic aim for investigation of pneumonia is to establish the diagnosis of the disease, to identify the pathogen, and then to assess the severity. Chest X-ray is very important and cornerstone in the investigation of pneumonia, because it will help us through the pattern of cavitation or pattern of lung affection. Because I have told you shortly here that pneumonia is a lower respiratory tract infection that is characterized by fever, chest symptoms and signs, and abnormal chest X-ray. So chest X-ray is an integral part for the process of investigation or confirmation of diagnosis in patient presenting with fever, cough, tachypnea, tachycardia, hypotension, and confusion. I mean, in patient presenting with features of pneumonia. Blood tests can be done here. Serology also is important in some particular situation, and the bronchoalveolar lavage can help us to identify certain organisms, as we will see as we proceed through this lecture. That for assessment of severity, this is a very integral and essential part in approaching the patient with pneumonia, is the assessment of severity or severity assessment in patient with pneumonia. By severity assessment, I mean that we use the CURB 65 score. And CURB 65 score refers to, the C refers to confusion, and I mean by confusion mental score less than 8, and U refers to urea more than 7, R refers to respiratory rate more than 30, and B refers to blood pressure Either we have a systolic blood pressure below 90 or the diastolic blood pressure below 60. And the 65 refers to the age of the patient, which is 65. These features, if they are present in patient with pneumonia, it can refer to a particular grade of severity. And according to the grade of severity, we can expect the mortality, and accordingly, it will guide us through the decision making regarding the treatment of the patient. Because I've mentioned to you before that being a physician, it's not your only responsibility to diagnose a disease, but your basic responsibility is to arrange a management plan, a reasonable management plan, and your basic responsibility is the decision-making process itself. So by severity assessment, it will guide you through the mortality of the patient and hence to the mode of treatment or what will you do, the plan for the patient. Okay, regarding this CARB 65 score in the clinical scenarios or in the questions that you have in the question banks, it will not be mentioned directly the CARB score of this patient, but the data will be dispersed within the clinical scenario, and you have to collect this data and calculate the CARB score, and according to the CARB score, your management plan will be defined. If the CARB score, if the CARB score is from 0 to 1, this is a low risk CARB score, and I mean by that the mortality is less than 3%, and this patient is advised for home treatment. But if the CARB score is 2, this means it's an intermediate risk, and here the mortality is from 3 to 15%, and this patient needs hospital therapy or admission to the hospital. If the CARB score is equal to or above 3, so this is a severe pneumonia, and this is a high risk patient, and the mortality is 15 to 40%, and you have to admit this patient to the intensive care unit or the intensive treatment unit. Other features that would help us in the severity assessment of patient with pneumonia includes coexisting disease, bilateral or multi-lobar involvement, respiratory failure, and respiratory failure is defined here by oxygen tension less than 8 kPa or saturation less than 92%. All these features will help you very well in order to define the severity of patient with pneumonia and hence the treatment of the management plan of this patient. For management of low severity community acquired pneumonia, amoxicillin here is the first line of treatment. And if the patient is allergic to penicillin, then we can use a macrolide or tetracycline. NICE recommends 5 days course of antibiotics for patient with low severity community acquired pneumonia. But if you have a patient presenting with moderate pneumonia according to the CARB 65 score and the high severity pneumonia according to the CARB 65 score, then you will need a dual antibiotic therapy is recommended for this patient with amoxicillin and a macrolide. The treatment course of duration is 7 to 10 days, and NICE again recommend considering beta-lactamase stable penicillin such as co-amoxiclav, ceftriaxone, or piperacillin with tazobactam and a macrolide in a high severity community acquired pneumonia. A lot of clinical questions, a lot of scenarios in the question banks that you have will tackle all of these areas, the choice of antibiotic therapy and the duration of therapy itself based on the CARB 65 score and the type of pneumonia presented. For all cases of pneumonia, you should repeat chest X-ray at 6 weeks after clinical resolution to ensure that consolidation has resolved and there is no underlying secondary abnormalities, just like lung tumors. In some clinical situations or some clinical condition, in a patient who have underlying lung tumor or lung cancer, it may complicate by a pneumonia, and the batch of pneumonia may overlay over the area of lung cancer. So the area of lung cancer will be obscured and it will not be visible in chest X-ray. So after resolution of the pneumonia, you wait for 6 weeks, and after that, you repeat the chest X-ray to look for any underlying pathology, just as lung tumor, and you will find a question about this particular piece of information in the question banks that you have. Let's move now to another important topic. This is the very core and very essential topic of pneumonia, which is the specific pneumonia. Remember, my friend, In the questions, you will have some direct questions about pneumonia, but you will have a lot of questions asking particularly about the specific pneumonias. Specific pneumonias follow the same structure as pneumonia. This is a lower respiratory tract infection characterized by fever, chest symptoms and signs with abnormal chest X-ray. And I have mentioned to you in the beginning of this lecture that radiological pattern of the radiological finding or the radiological features of patient of pneumonia is very important because it will define certain pathological conditions or certain diseases, and it will help us to define, diagnose them, and then to treat them appropriately. And now we start considering about this specific type of pneumonias by looking at the radiological patterns. This is very important, very essential, and very dangerous piece of information. A lot of questions are targeting specific pneumonias through the radiological pattern or the radiological features associated with each. Let's just start first by pneumococcal pneumonia. This is the commonest bacterial pneumonia, and it affects elderly and patients with post-splenectomy and even immunocompromised patients. This pneumonia starts by upper respiratory tract infection with herpes labialis, and then it will proceed to lobar pneumonia. And I mean by lobar pneumonia that there is an affection of one lobe of the lung. The treatment of a choice here is amoxicillin, benzyl penicillin, or cephalosporin. This is about pneumococcal pneumonia. The staphylococcal pneumonia is another specific type of pneumonia, and it's mostly associated with patients with intravenous drug abusers, leading to bilateral cavitating bronchopneumonia. And as you can see here, the lesion here or the pneumonia affects both the lung fields, so it's bilateral, and there are cavities or cavitating lesions, and it's called bilateral cavitating bronchopneumonia. The treatment of a choice here is flucloxacillin plus or minus rifampicin. In some patients with methicillin-resistant Staphylococcus infection or Staphylococcus species, we should consider vancomycin. This is a very important question in the exam. Klebsiella pneumonia is a rare type of pneumonia, but it affects elderly, diabetics, and alcoholics. The chest X-ray here shows cavitating pneumonia, particularly affecting the upper lobe, as you can see here. This is a CT scan of the chest showing a cavitating lesions affecting the upper lobes of the lung. Treatment here is by cefotaxime or empenem. Pseudomonas is another form of specific pneumonia, and Pseudomonas itself is a common pathogen and associated with bronchiectasis and cystic fibrosis, and may be also associated with hospital-acquired pneumonia. You will find these three different clinical scenarios here. One scenario about bronchiectasis, the other one about cystic fibrosis, and the third about hospital-acquired pneumonia. And I have told you that hospital-acquired pneumonia is pneumonia that develops after 48 hours of hospital admission. Treatment in this patient includes anti-pseudomonal penicillin, ceftazidime, meropenem, or cephalosporin, or ciprofloxacin with aminoglycosides. This is very important and take care of this pseudomonas pneumonia. Mycoplasma pneumonia, another type of specific pneumonia, and it usually occurs in epidemics about every 4 years, or sometimes it can occur insidiously with a flu-like symptoms followed by a dry cough. The chest X-ray in mycoplasma pneumonia shows reticulonodular pattern or reticulonodular shadowing with patchy consolidation, often affecting the lower lobe. I have to remind you here that Klebsiella affects the upper lobe, and usually the lesion in Klebsiella is a cavitating lesion, while here in mycoplasma pneumonia it's a reticulonodular shadowing or a patchy consolidation affecting the lower lobe particularly. The diagnosis of the mycoplasma pneumonia is specific for its own, because it will not depend only on the chest X-ray finding, but it would need a PCR sputum or serology to confirm the diagnosis of mycoplasma pneumonia. Again, mycoplasma pneumonia is associated with cold agglutinins, and you will study this cold agglutinins and the process of autoimmune hemolytic anemia in the hematology chapter later on. But now I need you to know that mycoplasma pneumonia may be associated with or may be present present with autoimmune hemolytic anemia due to the presence of cold agglutinase, a very important clinical scenario, and it comes frequently in the exam. Complications of mycoplasma pneumonia includes skin rash in the form of erythema multiforme, Stevens-Johnson syndrome, meningoencephalitis or myelitis, and Guillain-Barré syndrome. The treatment of mycoplasma pneumonia is via clarithromycin or doxycycline or fluoroquinolones, including ciprofloxacin or norfloxacin. This clinical scenario is very important, and I can understand that if you start practicing questions today, you will be shocked. You will be shocked how much this clinical scenario is presenting itself in the questions. Let's move now to the Legionella pneumonia. This is another specific type, another specific form of pneumonia, and it's present actually in the water tank. It's present usually in the water tanks, kept at less than 60 degrees, and it's associated with hotel air conditioning or hot water systems, causing outbreaks of Legionnaire's disease. There are flu-like symptoms followed by a dry cough again and dyspnea with extrapulmonary manifestation. This is very specific to Legionella pneumonia. The presence of extrapulmonary manifestations or features that includes anorexia, diarrhea, vomiting, and some organ damage, including hepatitis, renal failure, and confusion, and maybe later on coma. This is a very specific, peculiar, and unique scenario. A lot of questions targeting Legionella in all the question banks, and you will find a question about Legionella in any exam, in any MRCP exam. There will must be a question about specific type of pneumonia, particularly Legionella. The chest X-ray shows bibasal consolidation. Labs may show lymphopenia, hyponatremia, deranged liver function test, urine analysis may show hematuria, and this is in contrast to this may put some confusion with mycoplasma. But in mycoplasma, we do not have extrapulmonary manifestations, including hepatitis or renal impairment or confusion or coma, as we can see in Legionella infection. Diagnosis here again is different from other diagnostic tools used in pneumonia, and it includes Legionella urine antigen or culture. Treatment is by fluoroquinolone for 2 to 3 weeks or clarithromycin. Okay, so you have to be careful about this clinical scenario. It's very important, and its differential diagnosis or the differentiation between Legionella and mycoplasma pneumonia. Chlamydia pneumonia is the commonest chlamydial infection, and it starts with pharyngitis, harshness of voice, otitis, and followed by pneumonia. And this presentation is very specific here because you will find no presentation like this in other types of pneumonia. It starts by being an entirely upper respiratory tract infection, then it's followed by a lower respiratory tract infection in the form of pneumonia. Diagnosis is chlamydophobia complement fixation test or PCR of invasive samples. I mean by that bronchoalveolar lavage. Treatment here is by doxycycline or clarithromycin. Chlamydophobia pistachii is another form again of specific pneumonia, and we call it pistazosis, and it's acquired from infected birds, typically from parrots. A lot of questions about this one. General manifestations, there are general manifestations of pneumonia. I mean, we have fever and we have chest symptoms and signs, and with that we have extrapulmonary features. Extrapulmonary features are legion here, but they are there, including meningoencephalitis, infective endocarditis, and again, you may find hepatitis, nephritis, rash, or splenomegaly. The chest X-ray is a patchy consolidation, as you can see, and diagnosis again by chlamydophobia serology, and the treatment is by doxycycline or clarithromycin. Let's move now to a very important topic as regarding the lung infection, which is the pneumocystis pneumonia or the pneumocystis jirovecii infection. This is a pneumonia in the immunocompromised patients or the immunosuppressed patients. And I have to remind you here that immunosuppression does not necessarily mean HIV infection, because immunosuppression can be present in any patient with lymphoma, leukemia, bone marrow suppression, intravenous drug abuser, patient with complicated diabetes, end-stage renal failure disease, patient with immunosuppressive therapy, patient receiving chemotherapy, patient receiving radiotherapy, patient with neutropenia for any cause, and patient on long-term steroid therapy. All these conditions can lead to immunosuppression. So don't get yourself stuck in the idea that immunosuppression means only HIV infection, because the list of causes of infection of immunosuppression is an extensive list. So you have to know about it, and the only way that you can collect all of this knowledge is by solving a lot of questions, because you will find a lot of clinical scenarios in the questions about immunosuppression and its relation to chest infection and pneumonia. Previously, this organism was called the pneumocystis carinii, but now it's called a pneumocystis jirovecii. This patient presents with a dry cough, and very important keyword here, exertional dyspnea, and reduced oxygen tension. In some clinical scenarios, on some question, you'll find that it's mentioned to you that this patient oxygen saturation falls on exertion. This is again very specific for pneumocystis pneumonia. Patient again may have fever and bilateral crepitations. And by the way, chest examination may be normal in patient with pneumocystis pneumonia. Chest X-ray can be normal or may show a bilateral perihilar interstitial shadowing, as you can see here. This is a bilateral perihilar interstitial shadowing. The diagnosis of pneumocystis pneumonia depends basically on direct visualization of the organism, either by induced sputum or bronchoalveolar lavage or in a lung biopsy specimen. The drugs that we can use for the treatment of pneumocystis pneumonia are high-dose cotrimoxazole or intravenous pentamidine by slow IV for 2 to 3 weeks. Steroid therapy are efficient and beneficial if we have severe hypoxia, and in HIV patient, we need prophylaxis if the patient have CD4 count of less than 200 or after the first attack of pneumocystis pneumonia. This was about pneumonia and the specific types of pneumonia. Now we are going to discuss the complications of pneumonia. The importance of this section is that the clinical scenario may tackle pneumonia from the backyard. I mean from the complications of pneumonia, not from the presentation. The question you will have about one of the complications of pneumonia, then it will proceed retrospectively to diagnose pneumonia, and you can reach your diagnosis through that. First of all, the first complication of pneumonia is respiratory failure. And we have respiratory failure. We have two types of respiratory failure. In pneumonia, there is a type 1 respiratory failure. And in the section of respiratory failure, we will discuss what is type 1 and what's type 2 and what is the difference between them. Pleural effusion, and mostly it's an exudation because this is an infection affecting the lung tissue, so the pleural effusion will be of exudative nature. Empyema means that there is a pus in the pleural space, and it should be suspected in any patient with a resolving pneumonia who develops a recurrent fever. This is the key word here. We have a patient who have a resolving pneumonia, a pneumonia on its way of recovery, then he develops a recurrent fever. We do pleural fluid aspiration, and typically the pleural fluid will be yellow and turbid at the same time with a pH of less than 7.2 with low glucose content and high LDH. This is defining of empyema. This is defining in empyema. The treatment of empyema is by chest drain under radiological guidance, and we do culture and sensitivity. We'll give antibiotics accordingly, and the complications may include pleural adhesions or loculations. Lung abscess is a very important complication of pneumonia and is usually defined as a cavitating area of localized suppurative infection within the lung. This is a cavitating area, as you can you can see, with a suppurative infection within the lung. By clinical examination, you will find a swinging fever in this patient, fever that comes and goes. Also, patient presents with cough, which is a purulent and full-smelling sputum because there is a pus inside here. We have this patient could have a pleuritic chest pain and also can have hemoptysis with weight loss, finger clubbing, and crepitation. Chest X-ray is again defining because you will find the walled cavity with a fluid level, The treatment here is by antibiotics as indicated by sensitivity, and they should continue until healed, and it takes almost 4 to 6 weeks to heal with a pause and with postural drainage. Lung abscess scenario is a very important scenario in the questions and in the exam itself. Let's move now to bronchiectasis. This is another type, another form of lung pathology that may be caused by infection. Bronchiectasis is defined as a chronic infection of the bronchi and bronchioles, leading to permanent dilatation of the airways. This is the key word here as very important. The etiology of bronchiectasis may be congenital or acquired. There are different clinical conditions or different pathologies that can lead to congenital bronchiectasis, including cystic fibrosis, Young syndrome, primary ciliary dyskinesis, Cartegner syndrome. Or bronchiectasis can be acquired, caused by post-infection, bronchial obstruction, or tumor or foreign body. A very important clinical scenario again. Allergic bronchopulmonary aspergillosis, hypogammaglobulinemia. You will find this question in the past medicine about the relationship between hypogammaglobulinemia and bronchiectasis, rheumatoid arthritis, ulcerative colitis, or finally it may be idiopathic. The importance of knowing different causes or different etiologies of bronchiectasis is very important because this represents the clinical setting or the clinical context by which bronchiectasis can develop and can present itself. Let's talk now about the Cartegner syndrome, and usually also it is known as a primary ciliary dyskinesis. The pathogenesis here is that, as you know, that bronchi is lined by a cilia. This cilia moves in a certain way to get rid of the secretions that is secreted inside the bronchi. But in Cartegner syndrome, we find a defective cilia or immobile cilia due to defect in the dining arm. Dining arm is the arm that is a particular structure of the cilia that helps its motility. And by the absence of this dining arm, there will be a defect in the motility of the cilia, leading to the immotile cilia. Features include dextrocardia or complete situs inversus. Dextrocardia, I mean the heart, instead of being on the left side, it will be shafted to the right side. And by complete situs inversus, I mean solitary organs will be shafted to the opposite side. I mean the liver usually on the right side, so it will be shifted to the left side, and the spleen was in the left side, so it would be shifted to the right side. I mean by that, this is situs inversus, including changing the position of the heart from left to right, changing the position of the liver from right to left, and the changing position of the spleen from left to right. Again, bronchiectasis may be one of the features of Cartegner syndrome, recurrent sinusitis, and subfertility due to diminished sperm mobility and defective ciliary action in the fallopian tube. The symptoms of bronchiectasis include persistent cough, purulent sputum, and intermittent hemoptysis. The signs, again, there are toxic manifestations, manifest as finger clubbing. There is a course in respiratory crepitations, wheezes, and this wheezes puts bronchiectasis in a direct differential diagnosis of asthma, COPD, and allergic bronchopulmonary aspergillosis. And by the end of this subchapter, you should be able to differentiate between different causes of wheezes because it's an important clinical scenario or important questions in the exam. Complications of bronchiectasis includes pneumonia, pleural effusion, pneumothorax, hemoptysis, cerebral abscess, and amyloidosis. The investigations of bronchiectasis. Here we do sputum culture to define the organism, and we do chest X-ray. Chest X-ray, now the pattern of chest X-ray in patient with bronchiectasis is very important because it will show a cystic shadows, as you can see here. There are cystic shadows, as you can see here. Second bronchial wall, as you can see here. Trim, second bronchial wall. The bronchial walls are second due to the chronic infection and due to the stocking of secretions inside the bronchi, leading to a peculiar and unique appearance. We call it the trim light and ring shadows. You can see here the ring shadows and the trim line, as you can see here. Here in the CT, this is, we call it the CT, we call it the honeycomb appearance because it looks like you know, the bees. This is like the bee home. Okay, it's a honeycomb appearance. The HRCT scan, it helps HRCT chest scan, a high resolution CT scan will help to assess the extent and the distribution of the disease, as you can see in this illustration. Investigations also can extend to include spirometry, and the spirometry, it will show an obstructive pattern, and it will add to the difficulty or the confusion between bronchiectasis and bronchial asthma on one side, because you know bronchial asthma is an obstructive lung disease, it's not an restrictive. And again, COPD, it's obstructive, not a restrictive. And allergic bronchopulmonary aspergillosis can present again with an obstructive pattern on spirometry. All of them share the same spirometry, but they do not share the same features. And by the end of our chapter, or by the end of studying the respiratory medicine, you must be able to differentiate between these different conditions. Bronchoscopy can be used to locate the site of the hemoptysis and to exclude obstruction as a cause of hemoptysis. Because if you suspect a foreign body or a tumor, you should do bronchoscopy because it would help you to exclude or rule out obstruction as a cause of bronchiectasis. Other tests include serum immunoglobulins, cystic fibrosis sweet test, aspergillus precipitans, or skin prick test. We use the aspergillus, we use the aspergillus precipitans or the skin prick test to differentiate between bronchiectasis and allergic bronchopulmonary aspergillosis, or to diagnose allergic bronchopulmonary aspergillosis as a precipitating cause for bronchiectasis. The treatment of bronchiectasis basically includes postural drainage with physiotherapy. This is a very integral part of the management of bronchiectasis. Antibiotics should be used according to the bacterial sensitivity, and patients known to culture Pseudomonas will require treatment with oral ciprofloxacin or intravenous antibiotics. If we have a patient with bronchiectasis who presents with more than 3 exacerbations per year, you should consider long-term antibiotic therapy. You will find the clinical scenario targeting this point. Bronchodilators can be used in the treatment of bronchiectasis, corticosteroids for allergic bronchopulmonary aspergillosis, and surgery may be indicated if you have a localized disease or to control severe hemoptysis. You will find in past this a scenario about the role of surgery in bronchiectasis. Please, I have to remind you about the question banks. Don't rely on single question bank. My recommendation is to practice all the question banks, past test, past medicine, and on examination. Because by practicing all the question banks, you will get exposed to a lot of ideas, a lot of different clinical scenarios, and you will look at the disease or the chapters that you have from different angles. And after that, you can get a global view of the disease itself or the chapters that you are studying. It's very essential. Don't stick to one question bank. This is my single one piece of advice. If you want to ask me about my single one piece of advice regarding how to pass the MRCP examination, I would tell you solve the secret question banks. Okay, this is very important. Let's now talk about cystic fibrosis. Cystic fibrosis is one of the commonest life-threatening autosomal recessive disorder, and some questions asking about the mode of inheritance of cystic fibrosis, and it affects Caucasians and leading to increased viscosity of the secretions, particularly in lung and pancreas. The etiology and pathology here is very important. questions asking about this because it will give you a clinical scenario about a patient presenting with features of cystic fibrosis, and you will find the questions about the pathology and the pathogenesis and the etiology associated with cystic fibrosis. So do not neglect this slide, please. It's very important. Cystic fibrosis is caused by mutations in a cystic fibrosis transmembrane conductance regulator gene. This gene is present on the chromosome 7. You might be asked about the mutation, and you might be asked about the chromosome itself. We have almost more than 800 mutations have been identified that are related to the cystic fibrosis. The cystic fibrosis, again, is characterized by a chloride channel defect. Chloride channel defect. Again, some questions asking particularly about this pathology. Some organisms are associated with cystic fibrosis, and most important of them includes Staphylococcus aureus, Pseudomonas aeruginosa, Burkholderia species, and Aspergillus. These are the organisms associated with cystic fibrosis. Clinical features are variable according to the age of presentation. If you have a neonate presenting with congenital bronchiectasis, there will be a failure to thrive, meconium ileus, or rectal prolapse. But in children and young adults, the presentation is difficult because now it will affect different systems, including respiratory, gastrointestinal, and other systems. For the respiratory symptoms, this patient may have cough with wheeze, recurrent infection, bronchiectasis, pneumothorax, hemoptysis, respiratory failure, or cure pulmonaire. These are the respiratory findings associated with cystic fibrosis. Gastrointestinal manifestations include pancreatic insufficiency, because I have told you there is a secretion of increased viscosity in the lung and pancreas. So it's expected to have some features of pancreatic insufficiency, including diabetes mellitus and steatorrhea. Distal intestinal obstruction syndrome mimicking meconium ileus, so we call it meconium ileus equivalent, gallstones, and cirrhosis. Other features include mere fertility or subfertility, osteoporosis, arthritis, vasculitis, nasal polyps, sinusitis, and hypertrophic pulmonary osteoarthropathy. And by hypertrophic pulmonary osteoarthropathy, you'll find the swelling in the rest of this patient, which is a painful swelling. It will be mentioned to you like that in the questions, in the question banks that you have. The signs include cyanosis, finger clubbing, and bilateral course crepitations. How can we diagnose cystic fibrosis? We can diagnose cystic fibrosis by sweet test, and the sweet test will show us a sweet sodium and chloride more than 60 millimole per liter, with chloride usually more than sodium. Genetic testing or genetic screening, we can do genetic screening for known common cystic fibrosis mutation should be considered, particularly in family members of patients with cystic fibrosis and fecal elastase. Fecal elastase is a very simple test and used as a screening test for the exocrine pancreatic dysfunction. Other tests include blood test, full blood count, urea and electrolytes, liver function test, and so on. Bacteriology is very important because we need to do sputum culture to define the sensitivity of organisms associated with infection in patients with cystic fibrosis. By chest X-ray, we can find the hyperinflation and bronchiectasis, because I have mentioned in bronchiectasis that one of the causes of bronchiectasis is cystic fibrosis. Abdominal ultrasound is indicated because it may show fatty liver, cirrhosis, or chronic pancreatitis. Spirometry, it will give us an obstructive pattern of respiratory function test. And when we move to the obstructive and restrictive lung disease, we will understand what is meant by obstructive versus restrictive diseases. Aspergillus serology and the skin test is also important because 20% of patients may develop allergic bronchopulmonary aspergillosis, and by biochemistry, we need fecal fat analysis because it's a marker of pancreatic insufficiency. Management of cystic fibrosis should involve a multidisciplinary team. The key points here is that we need regular at least twice a day chest physiotherapy and postural drainage. We need high calorie diet for this patient, including high fat intake, because this patient has a pancreatic insufficiency, so fat absorption is compromised in this patient. For again, patient with cystic fibrosis should minimize the contact with each other to avoid cross-infection. Vitamin supplementation is very important because we have pancreatic insufficiency in this patient. Pancreatic enzyme supplementation should be taken with meal to replace the pancreatic insufficiency, and the lung transplantation is our final result, and this is the only effective mode of treatment. Chronic infections with Burkholderia septicemia is an important contraindication to lung transplantation. You will find some clinical scenarios or questions that the question brings, particularly about this piece of information. If you have a patient with cystic fibrosis who is infected by this organism, this represents an absolute contraindication to lung transplantation. We have a new agent, which is Lomacaftor and Ivacaftor. These are two new agents used in the management of cystic fibrosis, and they have been approved by the NICE as the management of cystic fibrosis. And this agent are used particularly and only in patients with Delta F508 mutation. You will find a question asking about this information. We have two molecules, the Lomacaftor and the Ivacaftor. Lomacaftor increases the number of the CFTR proteins, which are the cystic fibrosis transmembrane conductance proteins. This is the mechanism of action. You will find the question asking about this mechanism of action. And the Ivacaftor is a potentiator for CFTR proteins. It potentiates the action of the already existing CFTR proteins, but the Lomacaftor increases the number of the CFTR proteins itself. A question here, a question here, a question here. In this slide, you can find the three questions, as you can see. Okay. I will stop here for today because I do not want to overwhelm you. I need you to acquire and absorb all the data that we have mentioned today, digest them, start solving the questions, a lot of questions to be able to differentiate between different types of pneumonia, to be able to answer any question about bronchiectasis, any question about cystic fibrosis. I will stop here for today as a section of fungi and the lung. Next lecture, we will take fungi and the lung cancer, and we will start the respiratory function test with obstructive or restrictive lung disease. Okay, our next lecture will be on Saturday. On Saturday, we have an assessment before the lecture. It will be a cardiology assessment to understand how much knowledge you have acquired during the lectures of cardiology. If you have any questions, please do not hesitate to contact me, or if you have any question now, please do not hesitate to tell me.
All right, okay.
Okay, that's fine. Please, Dr. Lee, please, Dr. Ahmed, today, I will send you the record after a while. Today, start practicing the questions about pneumonia as much as you can. If you find any difficulty with any questions, don't just send me a WhatsApp. I will be very happy to answer you. Okay, thank you very much. Have a nice day, and Merry Christmas for everybody celebrating the Christmas, and Happy New Year for everybody who will be celebrating the Happy New Year. Merry Christmas to you, Dr. Lee. Merry Christmas to you, Dr. Ahmed, and Happy New Year.
Merry Christmas.
Merry Christmas. Thank you very much.